Hi, my name is Dr. Hussein Hadi from the Department of Pathology and Forensic Medicine at Mustansariya University. In these 4 lectures, I will try to talk about the endocrine system from the pathological point of view. Today, I will try to outline the pituitary gland and its disorders, including the anterior pituitary tumors, the hypopituitarism, and posterior pituitary syndromes. In addition, I'll try to talk about the thyroid and some of its disorders, including the hyperthyroidism and the hypothyroidism. And hopefully, in the coming lectures, I will continue the talk about the thyroid disorders, such as the autoimmune thyroid disease and the diffuse and multinodular goiter, as well as the neoplasm. In other lectures, I will try to talk about the parathyroid and the adrenal gland, and finally I'll talk about the men syndromes. So, the endocrine system is comprised of a widely distributed group of organs that work together to maintain the body's metabolic equilibrium or homeostasis. The cells of the endocrine system achieve this by secreting molecules called hormones. Typically is carried by the blood from the endocrine gland to its target tissues. Hormones can be classified into several broad categories based on the nature of their receptors. So I will start with the hormones that act by binding to cell surface receptors, which is composed of first peptide hormones such as growth hormones and insulin, and secondly the small molecules such as epinephrine. Binding of these hormones to cell surface receptors leads to an increase in intracellular secondary messenger such as cyclic AMP and inositol triphosphate and ionized calcium. Elevated levels of one or more of these compounds can activate intracellular signals pathway that may stimulate cell growth or differentiation or alter cell function. The other categories are hormones that act by binding to intracellular receptors. Many lipid-soluble hormones pass through the plasma membrane by diffusion to interact with the receptors in the cytosol or the nucleus. The resulting hormone receptor complex binds specifically to regulatory elements in DNA, thereby affecting the expression of specific target genes. Hormones of this type include steroids, for example estrogen, progesterone, glucocorticoids, and also the retinoids such as vitamin A, and finally the thyroxine. It is worth to know that the endocrine diseases generally are caused by, first, underproduction or overproduction of hormones, with associated biochemical and clinical consequences. Secondly, end organ resistant to the effects of a hormone. And third cause is the neoplasm, which may be non-functional or may be associated with overproduction or underproduction of hormones. Here I will try to talk about the pituitary glands and its disorders, including the anterior pituitary tumors, the hypopituitarism, and finally the posterior pituitary syndromes. The pituitary gland is a small bean-shaped structure that lies at the base of the brain within the confines of the sella turcica. It is closely related to the hypothalamus, with which it is connected by a stalk. composed of axons extended from the hypothalamus and a rich venous plexus, constituting a portal circulation. The pituitary has a central role in the regulation of most of other endocrine glands. It is composed of two morphologically and functionally distinct components, and these include A. the anterior lobe, which is called adenohypophysis, and B. the posterior lobe, which is neurohypophysis. Diseases of the pituitary, accordingly, can be divided into those that primarily affect anterior or posterior lobes. The anterior pituitary produces trophic hormones that stimulate the production of hormones from the thyroid, adrenal, and other glands. In routine histologic sections, a colorful array of cells containing either basophilic cytoplasm or eosinophilic cytoplasm, or even poorly stained, called the chromophobic cytoplasm, is present. As you can see in this figure, which is for the normal anterior pituitary glands, the normal microscopic appearance of the adenohypophysis is shown here. The adenohypophysis containing three major cell types, including the acidophils, basophils, and the chromophobes. The staining is variable and to poorly identify specific hormone secretion. A simplest classification is as follows. The pink acidophils secrete growth hormones and the prolactin. The dark purple basophils secrete corticotrophin, ACTH, and the thyroid stimulating hormone and gonadotrophins, including the follicle stimulating hormone and luteinizing hormone. Finally, the pale staining chromophobes have few cytoplasmic granules but may have secretory activity. The release of pituitary hormones, as seen in this figure, including the TSH, prolactin, and the ACTH growth hormone and the follicle stimulating hormone and luteinizing hormone, are under the control of factors produced in the hypothalamus. While most hypothalamic factors are stimulatory and promote pituitary hormone release, others are inhibitory, such as the somatostatin and dopamine. Now I will try to cover the symptoms and signs of pituitary disease, which fall into the following categories. First is the hyperpituitarism related effects. Hyperpituitarism arises from excessive secretion of trophic hormones. It most often results from an anterior pituitary adenoma. Secondly is hypopituitarism related effects. Hypopituitarism is caused by deficiency of trophic hormones and results from a variety of destructive processes that may damage the pituitary, including ischemic injury, surgery, radiation, and inflammatory reactions. The third category is called local mass effects. Among the earliest changes associated with pituitary neoplasms are radiographic abnormalities of the cella torsica, including cellular expansion, bony erosion, and disruption of the diaphragma cilia, may give rise to visual field abnormalities, and this is called the bitemporal hemianopia. In addition to signs and symptoms of elevated intracranial pressure, including headache, nausea, and vomiting. As I said in the beginning, I've tried to outline the anterior pituitary tumors, the hypopituitarism, and hopefully the posterior pituitary syndromes. So I'll start with the anterior pituitary tumors. The most common cause of hyperpituitarism is a hormones producing adenoma arising in the anterior lobe. Less common causes include hyperplasia and carcinomas of the anterior pituitary, secretion of the hormones by some extrapituitary tumors, and certain hypothalamic disorders. Some salient features of pituitary adenomas are as follows. First, pituitary adenomas are classified on the basis of hormones produced by the neoplastic cells, which are detected by immunohistochemical staining performed on tissue sections. Second, the pituitary adenomas can be functional, which means the hormone producing, or non-functional, that means not producing hormones, or even silent, that means demonstration of hormones production at the tissue level only, without clinical manifestations of hormone excess. The third feature is that the pituitary adenomas are designed as either microadenomas if they are less than 1 centimeter and macroadenomas if they are greater than 1 centimeter. And finally, non-functioning adenomas are likely to come to clinical attention at a larger stage. Because of their larger size, non-functioning adenomas may intrude upon and destroy adjacent anterior pituitary parenchyma, leading to hypopituitarism. This table is for the classification of pituitary adenomas and associated syndrome. In this lecture, I will try to cover most of these pituitary adenomas. You can notice in this table that the adenomas could either the lactotroph adenomas, which can secrete the prolactin and is associated with galactorrhea and amenorrhea in female and even sexual dysfunction and infertility. Secondly is the somatotroph adenomas can secrete the growth hormone, causing the gigantism in children and acromegaly in adults. The mama somatotroph adenomas can secrete both prolactin and growth hormone and causing the associated syndrome of combined features of growth hormone and prolactin excess. The fourth type is called the corticotroph adenoma, and this can secrete the ACTH, causing the Cushing syndrome. The other is the thyrotroph adenomas, and secreting the TSH, causing the hyperthyroidism. And finally, the gonadotroph adenomas, which can secrete the follicle stimulating hormone or luteinizing hormone and can cause the hypogonadism, mass effects, and hypopituitarism. For the pathogenesis, several genetic abnormalities associated with pituitary adenomas have been identified, including G protein mutations. They are one of the most common genomic alterations in pituitary adenomas. They play a critical role in signal transduction, transmitting signals from cell surface receptors, for example, growth hormone releasing hormone receptor, to intracellular effectors, for example, adenine cyclase, which then generate second messengers, for example, cyclic AMP. We should know that the G proteins are heterotrimeric proteins composed of a specific alpha subunit that binds the guanine nucleotides and interact with both cell surface receptors and intracellular effectors. In addition, the beta and gamma subunits are non-covalently bound to the alpha subunit. The alpha subunit of guanine is encoded by the guanine nucleotide binding protein subunit alpha isoforms and is called the genus gene. In the basal state, as seen in this figure, the guanines exist in an inactive state, with the guanine diphosphate bound to the guanine nucleotide binding site of the guanine alpha subunit. On interaction with the ligand-bound cell surface receptor, the guanine diphosphate dissociates and the guanine triphosphate binds to the guanine alpha subunit, activating the G protein, which leads to the generating the cyclic AMP, and this leads to the cellular proliferation and hormone synthesis and secretion. Normally, the guanine alpha subunit activation is transient because of an intrinsic GTPase activity in the alpha subunit, which hydrolyzes the guanine triphosphate into the guanine diphosphate. Approximately 40% of the somatotroph cells adenomas bear the genus mutations that abrogate the GTPase activity of the guanine alpha subunit, leading to constitutive activation of the guanine alpha subunit, persistent generation of cyclic AMP, and unchecked cellular proliferation. For the other genetic abnormalities, approximately 5% of pituitary adenomas arises as a result of an inherited predisposition. 4 genes have been identified as a cause of familial pituitary adenomas, including the menin-1, the cyclin-dependent kinase inhibitor 1B, as well as the protein kinase cyclic AMP-dependent regulatory subunit type 1 alpha, and finally the AIP, which stands for the aryl hydrocarbon receptor interacting protein. In addition, the molecular abnormalities associated with aggressive behavior include aberrations in cell cycle checkpoint genes, such as overexpression of the cyclin D1, mutation of the p53, and the epigenetic silencing of the retinoblastoma gene. In addition, activating mutation of the RAS oncogene are observed in rare pituitary carcinomas. For the morphology, the usual pituitary adenoma is a well-circumscribed soft lesion. Small tumors may be confined to the sella turcica, while larger lesions may compress the optic chiasma and adjacent structures, erode the sella turcica, and extend locally into the cavernous and sphenoidal sinuses. And 30% are non-encapsulated and infiltrate adjacent bone, dura, and uncommonly brain. Foci of hemorrhage and/or necrosis are common in larger adenomas. In the middle of this picture, you can notice massive non-functional adenoma has growing far beyond the confine of the sella turcica and has distorted the overlying brain. It is worth to note that the non-functioning adenomas tend to be larger at the time of diagnosis than those that secrete hormones. Microscopically, are composed of relatively uniform polygonal cells arrayed in sheets, cords, or papillae. This is called cellular monomorphism. In addition, absence of a significant reticulin network can be noticed as a supported connective tissue or reticulin is sparse. The nuclei of neoplastic cells may be uniform or pleomorphic. In addition, the cytoplasm of the constituent cells may be acidophilic, basophilic, or even chromophobic, depending on the type and amount of secretory product within the cell, but it is fairly uniform throughout the neoplasm. Here is a high-power microscopic view of an adenohypophyseal adenoma, and you can notice both the monomorphism of the cells as well as the absence of the reticulin network. Now I will try to talk about the functioning adenomas and hyperpituitarism. Adenomas arising from different pituitary cells produce hormones characteristic of the cell type and cause clinical syndromes that reflect the activity of the hormones. First of all is the lactotroph adenomas, prolactin secreting lactotroph adenomas. They are the most frequent type of hyperfunctioning pituitary adenoma. In addition, they account about 30% of all clinically recognized cases. They range in size from microadenomas to large expansile tumors associated with considerable mass effect. Prolactin is demonstrable within the cytoplasm of neoplastic cells by immunohistochemical techniques. The prolactin secretion is highly efficient, such that even microadenomas can secrete sufficient hormone to induce systemic symptoms. Moreover, hyperprolactinemia causes amenorrhea, galactorrhea, loss of libido, and infertility. Prolactinomas are diagnosed at an earlier stage in women of reproductive age than in others with these tumors. By contrast, the effects of hyperprolactinemia are subtle in men and older women, in whom the tumor may reach a larger size before coming to clinical attention. Next is the somatotroph adenomas, growth hormone secreting somatotroph adenomas. They are the second most common type of functioning pituitary adenoma and cause gigantism in children or acromegaly in adults. Because the clinical manifestations of excess growth hormone may be subtle, somatotroph cells adenomas may be quite large by the time they come to clinical attention. On microscopic examination, they are composed of densely or sparsely granulated cells, and immunohistochemical staining demonstrates growth hormone within the cytoplasm of the neoplastic cells. Persistent growth hormone excess stimulates the hepatic secretion of the insulin-like growth factor 1, which acts in conjunction with the growth hormone to induce overgrowth of the bones and muscle. We should know that if a growth hormone secreting adenoma develops before the epiphyseal close, as is the case in prepubertal children, excessive levels of growth hormone and insulin-like growth factor 1 result in gigantism. This condition is characterized by generalized increase in body size with disproportionately long arms and legs. If elevated levels of growth hormone and insulin-like growth factor 1 persist or developed after closure of the epiphysis, affected individuals develop acromegaly, in which growth is most noticeable in soft tissues, skin, and viscera, as well as the bones of the face, hands, and feet. Enlargement of the jaw results in its protrusion, and this is called prognathism. In addition, broadening of the lower face and separation of the teeth could occur. The hands and feet are enlarged, and the fingers are broad and sausage-like. Resistant growth hormone excess also is associated with metabolic abnormalities, the most important of which is diabetes mellitus. This arises because of the growth hormone induced peripheral insulin resistance. Other manifestations of growth hormone excess include gonadal dysfunction, generalized muscle weakness, hypertension, arthritis, as well as congestive heart failure. Thirdly is the corticotroph adenomas. Excess production of ACTH by functioning corticotroph adenomas leads to adrenal hypersecretion of cortisol and the development of hypercortisolism, also known as Cushing syndrome. When the hypercortisolism is caused by excessive production of ACTH by the pituitary, it is called Cushing disease. They are small microadenomas at the time of the diagnosis. These adenomas stain positively with PAS stains as a result of accumulation of glucosylated ACTH protein. ACTH also can be specifically detected by immunohistochemical method. Large clinically aggressive corticotroph cell adenomas may develop after surgical removal of adrenal glands for treatment of Cushing syndrome, this condition known as Nelson syndrome. Results from loss of inhibitory effect of adrenal corticosteroids on a pre-existing corticotroph microadenomas. Because the adrenal are absent, hypercortisolism does not develop. Instead, patients persist with the mass effects of the pituitary tumor. In addition, patients with Cushing syndrome often have hyperpigmented skin because of increased production of melanocyte-stimulating hormone, which is derived from the same precursors as ACTH. I talked about the lactotroph, somatotroph, corticotroph adenomas. Now I will try to outline the gonadotroph adenomas. The gonadotroph adenomas are so named because they produce hormones, luteinizing hormone and follicle-stimulating hormone, that act on reproductive organs. These adenomas can be difficult to recognize because they secrete hormones inefficiently and variably, and the secretory products usually do not cause a recognizable clinical syndrome. They are typically detected when the tumors become large enough to cause signs and symptoms related to local mass effects, such as impaired vision, headaches, diplopia, or pituitary apoplexy. The neoplastic cells usually demonstrate immunoreactivity for the common gonadotropin alpha subunit and the specific beta follicle-stimulating hormone and beta luteinizing hormone subunits. We should know that the follicle-stimulating hormone usually is the predominant secreted hormone. Finally is the thyrotroph, thyroid-stimulating hormone producing adenomas, accounts for about 1% of all pituitary adenomas and constitute a rare cause of hyperthyroidism. After the anterior pituitary tumors, the next subject is the hypopituitarism. Clinically significant hypopituitarism may occur with loss of or absence of 75% or more of the anterior pituitary parenchyma. It may be congenital, exceedingly rare, or result from a wide range of acquired intrinsic abnormalities of the pituitary, or less frequently hypothalamic origin. Most cases of the anterior pituitary hypofunction are caused by the following. First, tumors and other mass lesions, especially non-functioning pituitary adenomas. Secondly, ischemic necrosis of the anterior pituitary, called Sheehan syndrome, or postpartum necrosis of the anterior pituitary, is the most common form of clinically significant necrosis of the anterior pituitary during pregnancy. The anterior pituitary enlarges mainly because of an increase in the size and number of prolactin secreting cells. This hyperplasia is not accompanied by an increase in blood supply from the lower pressure hypophyseal portal venous system. The enlarged gland is thus vulnerable to ischemic injury, especially in women who experience hypotension during the peripartal period. By contrast, the posterior pituitary receives its blood directly from arterial branches and is much less susceptible to ischemic injury. Pituitary necrosis also may occur in the setting of DIC, sickle cell anemia, elevated intracranial pressure, traumatic injury, and shock of any origin. Third is the iatrogenic causes, include ablation of the pituitary by surgery or radiation. Next is the other less common causes of anterior pituitary hypofunction, include inflammatory lesion, for example sarcoidosis or tuberculosis, trauma, and metastatic tumors involving the pituitary. The clinical manifestations of the anterior pituitary hypofunction depend on the specific hormones that are lacking, such as the growth hormone deficiency. In children, growth failure, pituitary dwarfism may occur. In addition, gonadotropin or gonadotropin-releasing hormone deficiency leads to amenorrhea and infertility in women and to decreased libido, impotence, and loss of pubic and axillary hair in men. In addition, the TSH deficiency results in hypothyroidism, while ACTH deficiency results in hypoadrenalism. The prolactin deficiency results in failure of postpartum lactation. Finally, the anterior pituitary also is a rich source of the melanin-stimulating hormone, synthesized from the same precursor molecule that produces ACTH. Therefore, one of the manifestations of hypopituitarism is pallor of the skin from loss of stimulatory effects of melanin-stimulating hormone on melanocytes. The next topic is the posterior pituitary syndromes. The posterior pituitary or neurohypophysis is composed of modified glial cells and axonal processes extending from nerve cell bodies in the supraoptic and paraventricular nuclei of the hypothalamus. Hypothalamic neurons produce two peptides, the antidiuretic hormone and the oxytocin. They are stored in axon terminals in the neurohypophysis and released into the circulation in response to appropriate stimuli. For the antidiuretic hormone, it is regarded as a non-peptide hormone synthesized predominantly in the supraoptic nucleus in response to several different stimuli, including increased plasma osmotic pressure, left atrial distension, exercise, and certain emotional states. Antidiuretic hormone is released from axon terminals in the neurohypophysis into the general circulation. The hormone acts on the collecting tubules of the kidney to promote the resorption of free water. The other hormone is the oxytocin, which stimulates the contraction of smooth muscle in pregnant uterus and of muscle surrounding the lactiferous ducts of the mammary glands. Impairment of the oxytocin synthesis and release has not been associated with significant clinical abnormalities. The clinically important posterior pituitary syndromes involve antidiuretic hormone under or overproductions. First, the antidiuretic hormone deficiency causing the diabetes insipidus. It is a condition characterized by excessive urination, which is polyuria, due to an inability of the kidney to resorb water properly from the urine. Diabetes insipidus can result from head trauma, neoplasms, and inflammatory disorders of the hypothalamus and pituitary, and from surgical procedures involving the hypothalamus or pituitary. It sometimes arises spontaneously, that means it is idiopathic. We should know that the diabetes insipidus from antidiuretic hormone deficiency is designated central to differentiate it from nephrogenic diabetes insipidus, which is caused by renal tubular unresponsiveness to circulating antidiuretic hormone. The clinical manifestations of both diseases are similar and include the excretion of large volumes of dilute urine with an inappropriately low specific gravity. Serum sodium and osmolality are increased as a result of excessive renal loss of free water, resulting in thirst and polydipsia. Finally, is the syndrome of inappropriate antidiuretic hormone secretion. There is antidiuretic hormone excess, result in resorption of excessive amounts of free water, causing hyponatremia. Causes of syndrome of inappropriate antidiuretic hormone include the secretion of ectopic antidiuretic hormone by malignant neoplasm, particularly small cell carcinoma of the lung, non-neoplastic disease of the lung, and local injury to the hypothalamus or neurohypophysis. The clinical manifestation of the syndrome of inappropriate antidiuretic hormone are dominated by hyponatremia, cerebral edema, and resultant neurologic dysfunction. Although total body water is increased, blood volume remains normal, and peripheral edema does not develop. This figure demonstrates the hypothalamus pituitary thyroid axis and mechanism of action of thyroid hormones. Decreased level of T3 and T4 stimulate the release of TRH from the hypothalamus and the TSH from the anterior pituitary, causing T3 and T4 levels to rise. Accordingly, elevated T3 and T4 levels suppress the secretion of both TRH and TSH. This relationship is termed a negative feedback loop. You can also notice that the TSH binds to the TSH receptor on the thyroid follicular epithelium, causing the activation of G protein and the release of cyclic AMP. And this is mediate the synthesis and release of thyroid hormones. In this section, I'll try to talk about the thyroid gland and its disorders, including the hyperthyroidism and hypothyroidism. And hopefully, in the next lecture, I will try to outline the autoimmune thyroid disease, diffuse and multinodular goiter, as well as the thyroid neoplasm. Thyroid gland consists of two bulky lateral lobes connected by a relatively thin isthmus, usually located below and anterior to the larynx. It develops from an invagination of the developing pharyngeal epithelium that descends from the foramen cecum at the base of the tongue to its normal position in the anterior neck. The thyroid is divided into lobules, each composed of about 20 to 40 dispersed follicles. These follicles are lined by cuboidal to low columnar epithelium, which is filled with thyroglobulin, the iodinated precursor protein of activated thyroid hormone. In response to trophic factors from the hypothalamus, thyroid-stimulating hormone is released by thyrotrophs in the anterior pituitary into the circulation. The binding of the TSH to its receptor on thyroid follicular epithelial cells results in activation and conformational change in the receptor, allowing it to associate with a stimulatory G protein. The activation of stimulatory G protein results in an increase in intracellular cyclic AMP levels, which stimulates thyroid hormone synthesis and release. You should know that the thyroid follicular epithelial cells convert thyroglobulin into T4 and lesser amount of T3. T4 and T3 are released into the systemic circulation, where most of these peptides are bound to circulating plasma proteins. The binding proteins maintain the serum free T3 and T4 concentrations within narrow limits while ensuring that the hormones are readily available to the tissues. In the periphery, it is important to note that the majority of free T4 is deiodinated to T3. The latter binds to thyroid hormone nuclear receptors in target cells with the tenfold greater affinity than T4 and has proportionately greater activity, creating a hormone receptor complex that regulates the transcription of a subset of cellular genes. This process produces diverse cellular effects, including increased carbohydrate and lipid catabolism and protein synthesis in a wide range of cell types. The net result of these processes is an increase in the basal metabolic rate. For the rest of this lecture, I will try to talk about both the hyperthyroidism and hypothyroidism. The thyrotoxicosis is defined as a hypermetabolic state caused by elevated circulating levels of free T3 and T4 because it is caused most commonly by hyperfunction of the thyroid gland. Thyrotoxicosis often is referred to as hyperthyroidism. In certain conditions, however, the oversupply either is related to excessive release of performed thyroid hormone or comes from an extrathyroidal source rather than a hyperfunctional gland. Thyrotoxicosis has different causes, which could be associated with hyperthyroidism. As a primary cause, include Graves' disease, toxic multinodular goiter, toxic adenoma, and iodine-induced hyperthyroidism. As a secondary cause, the TSH-secreting pituitary adenoma is regarded as a rare cause. In addition, thyrotoxicosis may not associate with hyperthyroidism, and the example of these are the granulomatous thyroiditis and the subacute lymphocytic thyroiditis. We'll try to cover most of these causes in the coming lectures. For the clinical manifestation of thyrotoxicosis, they are variable and are attributable to the hypermetabolic state and overactivity of the sympathetic nervous system. And these include first the constitutional symptoms, at which the skin tends to be soft, warm, and flushed because of increased blood flow and peripheral vasodilation to increase heat loss. In addition, heat intolerance and excessive sweating are common. Moreover, weight loss, despite increased appetite, could occur because rise in sympathetic activity and hypermetabolism. For the GIT, malabsorption and steatorrhea could occur, resulted from the stimulation of the gut hypermobility. Third is the cardiac manifestation, as palpitation and tachycardia are common, which is increased cardiac contractility and increased peripheral oxygen requirements. Neuromuscular manifestations. Frequently, the patient experiences nervousness, tremor, and irritability resulted from the sympathetic overactivity. Nearly 50% develop proximal muscle weakness, and this is the thyroid myopathy. Regarding the ocular changes, they are often called attention to hyperthyroidism, which include a wide staring gaze and lid lag, are present because of sympathetic overstimulation of the superior tarsal muscles, which functions alongside the levator palpebrae superioris muscle to raise the upper eyelid. However, full-blown thyroid ophthalmopathy associated with proptosis is a feature seen only in Graves' disease. The next clinical manifestation is called thyroid storm. Designates the abrupt onset of severe hyperthyroidism. It occurs most often in patients with Graves' disease and probably results from an acute elevation in catecholamine levels, as might be encountered during infection, surgery, cessation of antithyroid medication, or any form of stress. It is a medical emergency, as a significant number of untreated patients die of cardiac arrhythmias. The final manifestation is hepatic hyperthyroidism, refers to thyrotoxicosis occurring in older adults in whom the typical features of thyroid hormone excess often are blunted. The underlying thyroid disease is usually detected during laboratory workup for unexplained weight loss or worsening cardiovascular disease. The diagnosis of hyperthyroidism is based on clinical features and laboratory data. The measurement of serum TSH is the most useful single screening test for hyperthyroidism because TSH levels are decreased even at earliest stages when the disease may still be subclinical. In rare cases of pituitary or hypothalamus associated secondary hyperthyroidism, TSH levels are either normal or raised. A low TSH value usually is associated with increased level of free T4. In the occasional patient, hyperthyroidism results predominantly from increased circulating level of T3, and this is called the T3 toxicosis. In such cases, free T4 levels may be decreased, and direct measurement of serum T3 may be useful. Measurement of radioactive iodine uptake by the thyroid gland could also be used. Such scans may show diffusely increased uptake in Graves' disease or increased uptake in a solitary nodule in toxic adenoma or even decreased uptake in thyroiditis. The next topic is hyperthyroidism. The hyperthyroidism is caused by structural or functional dearrangements that interfere with thyroid hormone production. This table shows the main causes of hypothyroidism, which could be either primary or secondary central causes. The best example of primary causes are post-ablative, including surgery, radioiodine therapy, or external radiation. In addition, the Hashimoto thyroiditis and iodine deficiency is regarded as a primary cause. There are some rare causes, including the congenital biosynthetic defects and some genetic defects. For the secondary causes, they are also regarded as rare, including the pituitary failure and hypothalamic failure. The clinical manifestations of hypothyroidism include cretinism and myxoedema. In cretinism, hypothyroidism developing in infancy or early childhood. This disorder formerly was fairly common in areas of the world where dietary iodine deficiency is endemic, and this is called the endemic cretinism. It is now much less frequent because of the widespread supplementation of salt with iodine. By contrast, enzyme defects that interfere with thyroid hormone synthesis are a cause of sporadic cretinism. Clinical features of cretinism include impaired development of the skeletal system and central nervous system. As seen in these figures, the patient could have severe mental retardation, short stature, coarse facial features, a protruding tongue, and umbilical hernia. The severity of mental impairment in cretinism seemed to be influenced by the time of onset of the deficient state in utero. For the myxoedema, hypothyroidism could occur in older children and adults. The initial symptoms include generalized fatigue, apathy, and mental sluggishness, which may mimic depression. In addition, decreased sympathetic activity result in constipation and decreased sweating. Moreover, the skin is cool and pale because of decreased blood flow. There is reduced cardiac output, contributes to shortness of breath and decreased exercise capacity. Additionally, hypothyroidism promotes an atherogenic lipid profile, an increase in total cholesterol and low-density lipoprotein levels that may contribute to the adverse cardiovascular mortality rates. Histologically, there is an accumulation of matrix substances called the glucosaminoglycan and hyaluronic acid in skin, subcutaneous tissue, and viscera. This results in non-pitting edema, broadening and coarsening of facial features, as well as enlargement of the tongue and deepening of the voice. In order to make the diagnosis of hypothyroidism, measurement of serum TSH is the most sensitive screening test. The serum TSH concentration is increased in primary hypothyroidism because of a loss of feedback inhibition of the TRH and TSH production by hypothalamus and pituitary respectively. The TSH concentration is not increased in individuals with hypothyroidism caused by primary hypothalamic or pituitary disease. In addition, the serum T4 is decreased in patients with hypothyroidism of any origin. These are some suggested readings. Hopefully, you will find it useful. Thank you.